Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips that may prove handy in your line of duty. Welcome to part 74 of our MCQ series measuring in toxicology. And the first question reads, lipid emulsion therapy has proved very effective in the management of beta blocker toxicity. So my question to you is, which of the statements listed below best explains this mechanism of action? Does it involve stabilization of the cardiac membrane? Does it involve an increase in sodium uptake through nodal cells? Does it involve an increase in cytosolic calcium concentrations, thus improving inotropy? Or does it involve bypassing of normal catecholamine generated influences on cyclic AMP and increasing cyclic AMP via other mechanisms which have been shown to increase pulse and blood pressure? I'll give you 10 seconds to choose the correct answer. There is an increase in cytosolic calcium concentration, thus improving inotropy. Now, lipid emulsion therapy may be of benefit in managing beta blocker toxicity. Now, glucagon may bypass normal catecholamine generated influences on CMP and increase CMP via other mechanisms which have been shown to increase pulse and blood pressure in beta blocker toxicity. So alternative D applies to glucagon, not to this particular modality. Now, sodium bicarb may be useful in the management of beta blocker toxicity in patients with a wide QRS interval because of the ability to inhibit inward sodium current during phase 4 of needle action potentials. Now, lipid emulsion therapy has 3 proposed mechanisms of action in beta blocker toxicity. That is encouragement of fatty acid transportation across the mitochondrial membrane to improve energy production in the myocyte. There is also proposed potential increase in cytosolic calcium concentrations, thus improving inotropy, and even there is proposed creation of a lipid sink, what we call a lipid sink, where lipophilic drugs are more likely to distribute into instead of tissue. I would just like to emphasize that lipid emulsion therapy can interfere with labs such as glucose, magnesium, and creatinine. Just as a by the way, let's move to the next question. The next question reads, Mr. PHB, a middle-aged male patient, is rushed to your accident and emergency department by a neighbor who witnessed him ingesting a substantial amount of paracetamol tablets 4 hours ago. So my question to you is, at which of the plasma acetaminophen concentrations listed below would you initiate IV N-acetylcysteine therapy? Would it be the 400 mics per ml mark, the 100 mics per ml mark, the 200 mics per ml mark, or the 50 mics per ml mark? I'll give you 10 seconds to choose the correct answer. So I would settle for the 200 mics per ml mark. Now, plasma acetaminophen concentration of at least 200 micrograms per ml at 4 hours from ingestion indicates probable hepatotoxicity. So N-acetylcysteine should be recommended or initiated at that stage. Now, this is based on the Rumac Matthew nomogram, which starts at the 4-hour mark. I'd like to add that a paracetamol concentration less than the 150 mics per ml at 4 hours indicate no hepatic toxicity, so there is no need to immediately administer N-acetylcysteine. However, we should consider repeating the levels again to see if they are rising or not. Let's move to the next question, please. And it reads, Master LPP, a 3.5-year-old boy, is rushed to your accidental emergency by his mother, who informs your team that she noticed that the ferrous sulfate bottle LPP was playing with is now empty and the cap is off. She informs your team she had just refilled a prescription for this drug and that the bottle contained about 30 tablets. Master LPP weighs 20 kilos. Now, assuming he ingested all the 30 tablets, what is the approximate elemental iron dose? Remember, the tablets are 325 milligram tablets. So what is the approximate elemental iron dose Master LPP took? Is it 48.8 milligrams per kilo? Is it 98 milligrams per kilo? Is it 9.8 milligrams per kilo? Or is it 488 milligrams per kilo? I'll give you 10 seconds to choose the correct answer after computation. So B is the correct answer. It's around 98 milligrams per kilo. Now, ferrous sulfate tablets contain approximately 20% elemental iron. Now, the most appropriate answer is 98 milligrams per kilo, because when you multiply 30 by 325, you get 9,750 milligrams. Now, when you take 20% of that, it gives you 1,950 elemental iron, milligrams of elemental iron. When you divide it by the patient's weight, it becomes 1,950 divided by 20, which is approximately 97.5. That can be rounded off to 98 milligrams per kilo. That's how I got to answer B. I'd just like to add that toxic elemental iron doses encompass a wide range which varies between 10 and 65 milligrams per kilo. Now, early GI distress is a concerning finding in patients with reported iron ingestions. I'd like to remind you that serum iron levels should be drawn 4 hours after the last known dose, with levels greater than 500 mics per deciliter, with systemic evidence of toxicity prompting chelation therapy with IV Desferrioxamine. Now, the preferred route of administration in acute iron toxicity is IV, but I would like to emphasize that IM can be used if the IV route is not feasible or practical. let's move to the next question, please. And it reads, which of the pharmacologic effects listed below correspond to digoxin? Does it increase inotropy? Does it decrease inotropy? Does it decrease chronotropy? Does it increase chronotropy? I'll give you 10 seconds to choose the correct answer. Both A and C are correct. It increases inotropy and decreases chronotropy. Now, digoxin causes a greater force of contraction. That is a positive inotropic effect, and it reduces heart rate, which is a negative chronotropic effect. And that is the effect that is responsible for its rate control effect in atrial fibrillation. I would like to add that digoxin increases inotropy via inhibition of the sodium potassium ATPase pump, which is known to increase cytosolic calcium concentrations that allows actin and myosin fibers to interact to a greater degree in the ventricular myocardium. Now, inotropy is the force of contraction of the ventricular myocardium. Chronotropy corresponds to heart rate, and digoxin indirectly reduces pulse due to an increase in the parasympathetic activity on the AV nodal conduction. Remember that. Let's move to the next question, please. And it reads, which of the statements listed below most accurately describes the mechanism of action of beta blockers on cardiac conduction or activity? Is it vasodilation? Is it an increase in chronotropy? Does it reduce inotropy? Or does it increase dromotropy? I'll give you 10 seconds to choose the correct answer. Beta blockers reduce inotropy. Now, beta blockers inhibit automaticity of the nodal cells, and that leads to reductions in dronotropy, that is the conduction speed through the AV node, chronotropy, which is the rate of firing of the SA node, and inotropy, which is the force of contraction of the myocardium. Now, remember that beta blockers competitively inhibit beta 1 receptors, specifically in the SA node in the heart, and they inhibit beta blocker receptors on blood vessels. Now, dromotropy, I would like to remind you of your physiology, is the rate of AV nodal conduction, i.e. the speed of the action potential through the AV node. Chronotropy corresponds to the rate of firing of the SA node, which affects pulse or the heart rate. And inotropy is the force of contraction of the ventricular myocardium. And yes, by the way, lucitropy refers to the degree of relaxation of the ventricular myocardium. And I would also like to add that beta blockers reduce remodeling of the myocardium, and they protect against sudden cardiac death in patients with heart failure. So they are very useful in heart failure patients, whereas the non-dihydropyridine calcium channel blockers like diltiazem and verapamil don't have these properties. Now, remember that beta blockers, especially the non-selective ones, can inhibit beta 2 receptors on blood vessels, thereby causing vasodilation or unopposed alpha-1 vasoconstriction. Just as a by the way, let's move to the next question, please. And it reads, KPM, a middle-aged man, is undergoing a surgical operation under anesthesia in your OR. His temperature is rising abnormally fast. He develops muscular contractions. So my question to you is, which of the antidotes listed below would you administer to Mr. KPM now? Would you administer physostigmine, dantrolene, fomepizole, or N-acetylcysteine? I'll give you 10 seconds to choose the correct answer. I would settle for dantrolene, which is marketed as Dentrium. Now it blocks the calcium release via what we call the RYR receptor on the sarcoplasmic reticulum, and this causes malignant hyperthermia from excessive muscular contraction, since actin and myosin can only interact in the presence of calcium. Now N-acetylcysteine is an antidote for acetaminophen toxicity, so it's the wrong answer here. And physostigmine is used as an antidote for anticholinergic toxicity. And then fomepizole, which is antizole, or IV ethanol, are antidotes for antifreeze, that is ethylene glycol, and even methanol toxicity. So those would not be the right options in this particular case. Dantrolene would be the right answer. Let's move to the next slide, please. And the question reads, which of the metals listed below is chelated with dimercaprol in case of its toxicity? Is it organic mercury, thallium, iodine, organic mercury, or all of the above? I'll give you 10 seconds to choose the correct answer. Inorganic mercury it is. Now dimercaprol administration following elemental mercury vapor or exposure to organic mercury can cause soft tissue or brain concentrations to increase. Now when chelating mercury compounds, dimercaprol should only be used for chelation of inorganic mercury or elemental mercury. Remember, inorganic mercury compounds such as mercury plus sulfur, oxygen, or chloride can be chelated using dimercaprol. And organic mercury compounds, that is mercury plus carbon, e.g. methyl mercury, and elemental mercury shouldn't be chelated with dimercaprol due to potential for redistribution into the CNS. Now, human beings can be exposed to organic mercury compounds through consumption of fish or shellfish contaminated with methyl mercury. And dimercaprol should only be considered for inorganic mercury chelation when patients' GI tracts are compromised. Otherwise, in my opinion, saxima should be the chelator of choice when the GI is working. And then I would like to emphasize that accidental IV dimercaprol administration can lead to fat embolization, and it should be treated as a high-risk medication in your institutions. You should endeavor to classify dimercaprol as a high-alert medication because of this adverse event that could occur if you erroneously or accidentally administered dimercaprol intravenously. Let's move to the next question, please. And it reads, Mrs. T.A.J., a 59-year-old female, is being treated for deep venous or deep vein thrombosis in your medical ward, which developed after she underwent a total hip replacement surgery 4 days ago. Your clinical team infuses heparin at a rate of 1,500 units per hour, and Madam T.A.J. begins complaining of lightheadedness. Her primary nurse reports that her drainage from the wound has increased and it contains a lot of blood, in her own words. And TAJ's most recent HB is 9.4 milligrams per deciliter, and the clinical pharmacist is concerned about the heparin dose she is receiving. The APTT is repeated and it reads 180 seconds. The primary physician inquires about the protamine sulfate dose required to reverse the heparin given over the last 1 hour. So my question to you is, which of the protamine sulfate doses listed below would be the most appropriate in this clinical scenario? Would it be 50 milligrams, 15 milligrams, 30 milligrams, or 7.5 milligrams? I'll give you 10 seconds to choose the correct answer. Would administer 15 milligrams. Now, approximately 1 milligram of protamine sulfate is able to neutralize 100 international units of heparin in the blood. Now, the patient has at least 1,500 units of heparin at present, since that is the quantity that has been infused over the past 1 hour, and thus will require 15 milligrams of protamine sulfate. Now, protamine sulfate is the antidote used to reverse unfractionated heparin, and the dose is 1 milligram for every 100 units of heparin given actively via IV, which needs to be reversed. It can also reverse the low molecular weight heparin such as enoxaparin and dalteparin, and I would just like to caution you that it isn't as effective in the case of these low molecular weight heparins as it is in neutralizing unfractionated heparin being infused IV. Let's move to the next question, please. And it reads, Master MMM, a 7-year-old boy, was found lethargic in their dining room with an empty bottle labeled Lanoxin 0.2 milligrams. His grandmother is spending the vacation at their house and just had her Lanoxin prescription filled 7 days ago, which she uses for the management of her recently diagnosed heart failure. So my question to you is, which of the treatment options listed below would be the most appropriate for Master MMM now? Would you consider administering sodium bicarbonate, atropine, digibind, or would you administer activated charcoal slurry to this young man? I'll give you 10 seconds to choose the correct answer. I would administer digibind. Now, digibind is an antidote which is indicated for the treatment in a child who has ingested more than 4 milligrams of digoxin. Now, alternative D, activated charcoal, is reasonable to consider if administered within 1 to 2 hours of digoxin overdose and if the airway can be or is protected. Atropine may reverse bradycardia from vagal effects of digoxin on the AV node, with about 50% of patients showing improvement, but it's not the first line. I would like to add that sodium bicarbonate may be used if patients have hyperkalemia and a wide QRS. And then just remember that digibind is the most commonly used antidote in the case of acute digoxin overdose to bind digoxin and to prevent it from distributing into tissue. Remember, digibind also is indicated in the treatment of adults who have ingested more than 10 milligrams of digoxin. It is also indicated in acute ingestion where levels are greater than 10 nanograms per ml, in chronic toxicity where the levels are greater than 6 nanograms per ml, and in the presence of cardiac dysrhythmia that can't be corrected by other treatments, and even in cases where serum potassium exceeds the 5.5 milliequivalents per liter mark in acute ingestion, or in cases of toxicity with plant-derived digoxin. And then I would like to add that for acute digoxin ingestion, all the 10 vials in the DigiBind kit should be administered, since one vial is able to bind 0.5 milligrams of digoxin. Now, for the case of chronic digoxin toxicity, it's recommended in literature that you start with 1 to 2 vials of DigiBind and then repeat pro renata if need arises. Let's move to the next slide, please. And the question reads, bone tissue is the primary site of action for added calcium disodium during lead chelation therapy. So my question is, with which of the agents listed below should it be co-administered to prevent lead redistribution into the central nervous system? Would it be with the Desferrioxamine, N-acetylcysteine, dimercaprol, or Prucine Blue? I'll give you 10 seconds to choose the correct answer. It should be co-administered with dimercaprol. Now, for severe lead toxicity, dimercaprol should be started 4 hours prior to the first dose of added calcium disodium. Remember that dimercaprol is a lead chelator and it prevents redistribution of lead from bone to soft tissue such as the brain. And dimercaprol can cause adverse reactions which include hypertension, tachycardia, severe nausea and vomiting, and even prolongation of prothrombin time. So even as you use it, be very, very cautious and careful. Now, since intramuscular administration of dimercaprol is painful, co-administration of local anesthetics such as lidocaine is recommended and acceptable at the site of administration of dimercaprol. And then I would like to add that topical dimercaprol can be used if the patient had dermal exposure to vesicants. For topical application, the 10% ampule should be diluted with vegetable oil to a concentration of 5 prior to administration. Let's move to the next question, please. And our final question reads, Master TJK, a 5.5-year-old boy, is rushed to your accident and emergency department by an uncle on noticing a ferrous sulfate bottle the boy was playing with is empty with its cap off. Could have swallowed all its contents. Now the uncle reports that this was a newly filled medication for his anemia management, which had approximately 30 tablets. So my question to you is, which of the treatment options listed below would be the most appropriate for Master TJK now? Would you administer oral desferrioxamine? Would you administer syrup of ipecac? Would you do oral gastric lavage, or would you administer activated charcoal slurry? I'll give you 10 seconds to choose the correct answer. So I'll do orogastric lavage. Now, GI decontamination strategies, including vomiting or activated charcoal, aren't recommended for iron ingestion, so don't use them. Now, oral desferrioxamine can actually increase iron absorption, since ferroxamine, which is the chelated product, is absorbed in the GIT. So that would backfire on us. Then I would like to add that oral gastric lavage is an appropriate strategy in patients with toxic iron ingestions, and it should be performed in patients with potentially toxic iron ingestions, that's above the 60 milligrams per kilo, provided that their airway can be protected. I would like to add that abdominal X-ray films may detect iron tablets. However, this technique isn't 100% sensitive or specific. Then just remember that whole bioirrigation with propylene glycol 3350 can be used with orogastric lavage. Then I'd like to remind you that patients with potentially reported toxic ingestions who are asymptomatic 6 to 8 hours after ingestion can be discharged pending psychiatric evaluation. So, ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of this video. Now, if it benefited you in any way, I would like to urge you to please give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. I sincerely thank you very much for viewing it and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to interacting with you in part 75 for our MCQ series. Thank you very much.